मन में आ जाए कि जो पेशेंट मेरा डॉक्टर ट्रीट कर रहा है उसने गलत काम किया है। ये बहुत ज़रूरी है कि आप कोई ऐसे रिमार्क, कोई पेशेंट का सेकंड ओपिनियन के लिए आया या कुछ आया, उस पर ध्यान करें।
थैंक्स अ लॉट, वेरी गुड।
थैंक यू सो मच।
नरेश गुप्ता
सर एक छोटा सा सवाल।
सर,
ये सवाल नहीं है सर, मेरी सोच है। आई एम थिंकिंग वाई इन द मेडिक्लेम्स विच वाज यूजुअली difficult to get the claims, now it is not.
Indemnity.
The motor claims were also difficult to get, but now it is not. To the extent they have started a zero depreciation models. Why in the indemnity this problem is coming? It is because what I feel is the amount of premium which we give in proportion to the claims which are there.
It's peanuts
There is
actually,
a-
yes.
It's a vast this thing, which I feel will be reduced, and once that is reduced, like a zero depreciation policy, this will include everything. They will not find excuses for refusing it. I think what is required is a look into the indemnity policy as a whole. And,
So
there
what the
might be
insurance,
changes.
sorry to interrupt you, I was just, just to support your statement. Insurance companies are going to increase the premium sharply. If you are paying like, as I said, for 1 crore rupees, only 4,500 or 5,000 rupees, it is going to be increased sharply. It is peanuts actually, and it has been there for at least 20, 30 years, same amount, So it is going to increase very quickly, and it is going to be very high now.
Excuse
Narayan
me, sir.
if want to say something, Arvind Narayan sir.
Dr. Pankaj, I will answer your. Dr. Pankaj, you asked, yeah. The answer is that because actually, if even you are working at the corporate hospital or the hospital where you are working to the responsibility, it is called as the vicarious responsibility, and hospital cannot deny his responsibility. But the problem lies with in the court actually. The primary responsibility lies with the treating physician or surgeon. So you have to take care of yourself. Though hospital will have its own responsibility, but that's primary responsibility you. So you have to take your own legal consultations.
Sir, I'm sorry, but I wanted to ask you a question from an OPD perspective. Like, if for OPD, what is the time frame I have to keep my documentation, and what is the procedure for that, sir? If I'm not attached to hospital, I just have my OPD. How should I do it for this?
So there are at least 10 or 11 laws which guide the amount of time that you have to, preserve the documents. For OPD, as per NMC, you do not have to keep any records. But at the same time, there is another law which says that effort should be made for electronic documentation. So what I suggest is, it is not for the law, but to save your own behind, that you should preserve the records in perpetuity. See, I'm making a very big statement. Perpetuity means for lifetime. You scan it, preserve it, destroy the originals. It is all right after a few years, after 2, 3 or 4 years. And the electronic records, you keep it on a hard disk for a long time. The patient, maximum time that a consumer court has accepted a complaint from a patient against a doctor or from a, service provider is 10 years. और the consumer court law में है 2 साल का, ठीक है, कंज्यूमर प्रोटेक्शन एक्ट में, बट 10 years में भी उसको रिलैक्स करके उसने एक्सेप्ट कर ली, तो 10 years तक तो रखना ही है ना. तो इट इज टू सेव आवर ओन एस दैट वी हैव टू प्रिजर्व द डॉक्यूमेंट्स फॉर ए लॉन्ग टाइम. Okay, perpetuity is my answer.
Thank you so much,
Dr.
sir.
Dr. Gaurav,
Sir, Arvind.
all
Yes.
said and done, all these loopholes should be plugged. And at the level of IMA and DMA, as a team, we can just go ahead and
So
plug
DMA,
these
and please
loopholes.
take IMA headquarters also with you, because we can try to have it for the entire country. Why only think of
Has to
Delhi,
be,
you know?
It has to be.
Yes, sir.
Yes. It should be
Because
at the IMA
you are
level.
the leaders who will take it forward.
We'll
you know?
definitely take it.
Yes, sir.
With awareness, everybody will agree that we should take it.
Yes. So
Thank you
remarks
for
from-
such a wonderful talk,
Thank you,
Dr.
sir.
Gaurav.
Sir, just 30 seconds last. Dr. Deepak Jain, sir, one of the IMAs of we can say IMA Ghaziabad leaders, one of our pioneer is here. Sir was with us in first conference also. and we most of us are Dr. Naresh Gupta. So I want some question or concluding remarks on this.
You should
Then we-
represent the entire state of UP for new policy, sir, please.
Thank you, Dr. Gaurav, for the comprehensive presentation. In fact, I joined this session in the midway, so I'm not aware what happened in the last half an hour. I just want to ask one question. In what circumstances insurance company refuses to pay indemnity insurance to a doctor?
that was
Okay,
the-
so this was the talk about, and there are, many reasons. And I'll just summarize it one way. I'll share with the presentation with you. Sir, earlier the insurance companies were happily paying compensation, ठीक है, because cases कम होते थे. Now the cases are rising. And district courts are granting lakhs and crores of rupees, like, if it is, वो कहते हैं, डॉक्टर साहब तो आपको तो कुछ देना नहीं है ना, कंपनी देगी अपनी जेब से. So they are very happy granting compensation to patients. And patients now, it is not about the amount of money they have spent during treatment. It is about कि 60 years तक, अगर वो 25 साल या 30 साल तक का था जब डेथ हुई फॉर एग्जांपल, तो उस साल में कितना कमा सकता था, प्लस अगर 5 साल या 10 साल केस के चले तो वो इंटरेस्ट मिला के, तो द टोटल अमाउंट गोज few crore rupees easily. So my point is that, the amount of compensation is not decided by the amount that we are, वो कोर्ट से कहते हैं कि डॉक्टर साहब तो कंपनी देगी 1 करोड़ 2 करोड़ आराम से, तो आराम से compensation grant करते हैं, that is near to the amount that we are insured for. And there are many companies are, increasingly denying crores of rupees to patients on flimsiest of excuses.
Can compensation be awarded in the absence of any medical negligence? Proved
Yes.
in the court. Suppose
Yes.
there is no medical negligence.
Many cases, sir. Many cases. We've got many cases. For example, डॉक्टर की कोई गलती नहीं हुई, ठीक है, it might be a surprise to you. No negligence whatsoever. But if you are a surgeon and you performed gynecology surgery, 1 crore, 2 crore, easily granted. Qualification अगर प्रॉपर नहीं है, ठीक है, तो उस बेसिस पे हो जाता है. आपके यहाँ पेशेंट ठीक था, आपने सब कुछ ठीक ठाक ट्रांसफर कर दिया दूसरे हॉस्पिटल में, तो उसमें दूसरा हॉस्पिटल पार्टी बने चाहे ना बने, लेकिन आप ज़रूर बनेंगे व्हेन यू रेफर्ड द पेशेंट टू अनदर हॉस्पिटल. बट आपकी कोई गलती नहीं थी, स्टैंड डॉक्यूमेंटेशन सब कुछ ठीक है, बट इवन देन कुछ ना कुछ फॉल्ट इन कंसेंट फॉर्म में. मैं एक छोटा सा क्वेश्चन पूछता हूँ, बस सिंपल MCQ. हाउ मेनी सिग्नेचर शुड बी देयर इन ए कंसेंट फॉर्म? ऑप्शंस आर 1, 2, 3, 4, 5 or 6. What is the answer? Anybody except Dr. Arvind Arya? Anybody? Anybody else? 1, 2, 3, 4, 5 or 6 in a consent form. Because ये सबसे ग्रेव एरिया, ग्रेवयार्ड एरिया है. हमारा कंसेंट फॉर्म सब कुछ ठीक है, कंसेंट फॉर्म में प्रॉपर नहीं है. So most of us do not know it. There should be at least 4 signatures. Doctor and witness, you are right sir, and patient and witness. अगर कम है तो यहाँ भी नेग्लिजेंस आ गई. मतलब ऐसा नेग्लिजेंस ट्रीटमेंट में, मैनेजमेंट में नहीं है, बट कहीं ना कहीं डॉक्यूमेंट में वो, सी कंज्यूमर प्रोटेक्शन एक्ट इज अबाउट डेफिशिएंसीज, मिस्टेक्स. सब कुछ ठीक किया आपने, यू आर द बेस्ट डॉक्टर इन द वर्ल्ड, बट कहीं ना कहीं कागजों में कुछ कमी रह गई. 1 crore, 2 crore rupees easily patient will get from the insurance company or from your pocket. Thank you so much. Thank you, Dr. Pavan.
Thanks a lot. Thanks a lot, sir. A very nice session. I should appreciate. You have done wonders for all of us. Thanks a lot. So, in the interest of time, I will ask Dr. Namit to felicitate the mementos. And the next session, we will be going with the tide with Dr. Vibhut Pratap Singh. Dr. Vibhut is young, very senior intervention cardiologist. Dr. Vibhut is with Makkah of Cardiology, Fortis Escort Hospital, and the session will be basically on lipids, which we everybody wants to check. क्या आप lipid मेरा कितना रखना है, क्या रखना है, and the chairpersons for the session will be Dr. Ashok Sharma sir, please, Dr. Rajiv Singh sir, Dr. B.K. Gupta sir, Dr. B.K. Gupta sir, Rajiv Singh sir. Dr. Arjun Singh sir please. Dr. Dinesh Saraswat sir, if present here, please sir. So, Dr. Vibhuth is, as I have said, is a prestigious from prestigious KGMC Medical College, and a professional and a doctor and a very good person, very good cardiologist with multi-dimensional versatile functions. If we have to ask for the valve, the transvalvular treatment, he is one of our guy. If we have to ask for the complex intervention cardiology, he is one of them. And he is from Makkah of cardiology, I should again say, the Fortis Escort Hospital. So he will mesmerize us on this lipids. So to you, Dr. Vibhuth, please.
Thank you, sir. Thank you to all the chairpersons. Sir is like an elder brother to me, so don't be flattered by his praises. This is just like an elder brother praising his younger brother. And been really part of the SIRS conference since its inception, and it's really an honor to come here in East Delhi and have present the topic today. So without wasting the time, let us go forward to the topic, changing paradigm in lipid lowering therapies. I'm Dr. Vibhuth Pratap Singh. So what my basic whole goal of the presentation is, one, the LDL targets, what we are seeing the reduced LDL targets now, and second, the newer therapies, most particular the inclisiran. So as we all know, the burden of atherosclerotic cardiovascular disease is too much in India. The prevalence is around 54 million. It is a number one killer. The years life lost to the cardiovascular disease have increased 60%. And there is a direct economic burden. As a physician and as a clinician, what we see in the last decade, there has been a tremendous rise in the cardiac patients. The three risk factors, hypertension, diabetes, diet, they have been talked about a lot. Somewhere down the line, LDL levels were missing the whole game. Dyslipidemia, the patients are, we will be treating it in the next year, we'll go with the diet, and that LDL levels goes on without being noticed. LDL is involved in every step of atherosclerosis. Initial eNOS activity to the formation of foam cells, increasing foam cell formation, foam cell necrosis, and the necrotic core being ruptured. So it is involved in the total cascade of an myocardial infarction. Cholesterol control is fundamental in reducing risk of ASCVD. Lifetime exposure to elevated LDL-C is a causal and cumulative risk factor for ASCVD. So we are in between healthcare, patient and physician triage. Now the very important question, how low would you go with respect to the target? We had heard in the Dr. Rajiv Agrawal session, and these are the slides which you should focus in your clinical practice from here on. The LDL goal has changed. It has changed a lot from 2011 to 2023. You can see in the last decade, the goal itself has been changed. Starting from ESC 2011, in which less than 100 was okay, coming down to the Lipid Association of India guideline, in which extremely low levels of less than 40 were indicated. If we talk about the guidelines, the two guidelines that are very important are European Society of Cardiology guidelines, and the other is Cardiological Society of India guidelines. And I will be talking a brief about them. 2023 ESC guidelines say LDL reduction to less than 55. What we mean by LDL reduction is the direct LDL measurement. Remember the word, when you ask for fasting lipid profile, go for the direct lipid measurement, not the calculated. The reagent costs only 20 rupees, but the labs give the calculated. Go for the LDL-C direct. LDL-C reduction more than 50% from the baseline for patients who have experienced a second CV event within 2 years. And lot of our Indian patient goes LDL-C level of less than 40. This is how low we go. LDL-C is one of the top modifiable CVD risk factors. LAI had talked about extreme high risk lowering of this thing. We are focusing on ESC and the Cardiological Society of Guidelines. Why there is a huge unmet need for LDL-C goal? The patients who did not achieve LDL-C target, monitor your patients, see the LDL levels, and you will find this data resonating in your clinical practice. Around 60% of the patients are not getting to the LDL. We are very worst that we have to get A1C down below 7. Fix LDL to that level. 2023 LDL guidelines for the ACS patients. So what it says, if the patient is landing as an acute coronary syndrome, he's on high intensity statin, continue, check LDL. Low intensity, go for high intensity, that is rosuvastatin 40 or atorva 80. If he is not on intensity, statins, start the high dose initiation. And if the goals are not meeting, add a PCSK9, add a bempedoic acid, or add a ezetimibe. Now here, this is a CSI guidelines, and I want to focus you all on this thing. Very important, the concept change has been in this guideline, that the first very important thing we have been taught in Braunwald, fasting lipid profile. The first thing in the ACS patient, go for non-fasting lipid profile. Fasting is not required. Second thing, what they say is, go for combination therapy. This is the newer thing which American College of Cardiology is also talking. The Indian guidelines are also coming up. Straight away go with the combination. Rosua plus ezetimibe, atorva plus ezetimibe. Bempedoic acid is also catching up very fast because the bempedoic with compared to ezetimibe, 18% reduction as compared to ezetimibe 12%. But not talking into that, combination therapy is being advised, and then you should target the LDL-C level less than 55. Again, monitor the patient 6 weeks and 12 weeks. So important, non-fasting lipid profile, importance of combination therapy at onset, and the target of LDL goal. Now this was the CSI guidelines 2023, and there was a question, so I specifically got it incorporated just now in my presentation. You have to remember, this is how we target the lipid now. This is 2023 guidelines, hardly a year or two, we will be going more intense. Because this is one subset, as in practicing intervention cardiologist, I also feel that is most neglected. No risk factors is still LDL-C less than 100. Moderate risk factor, diabetes, hypertension, tobacco, family history, less than 100. High risk, all the patient going into less than 70. Generally, what we see in our clinical practice are extremely or very high risk. That was the reason Dr. Rajiv was saying LDL goal less than 55 or non-HDL-C targets of less than 85. So how soon do you recommend escalation of lipid lowering therapy in your post-ACS patient? Immediately. And the very important thing is the statin, the LDL goal is also there, plaque stabilization is also there. So patient who has an acute coronary syndrome, the first 90 days are critical for his re-event. So always be very particular about the cholesterol medication. Do not decrease the high intensity statins. ACS patients are at higher risk of a future events. Guideline recognize that early intervention is critical to improve outcome. So hit hard, hit early. That should be the buzzing mantra. Never shy from high dose statins. How to ensure access to early intervention? This is more for a corporate presentation as from the company itself. Pre-hospital, post-hospital, we should be taking that in mind. Now, very important, the talk that which I have to give, that novel therapies like inclisiran fit in the current lipid lowering space. So this is a wonderful drug, and this is really out of our pharmacology books which we were discussed and which we had read up. This is a therapy that is targeted RNA based. So what it does, inclisiran is selectively taken up by the hepatocyte with the help of GalNAc conjugates. It is stored in the endosome where it loads into RNA-induced silencing complex or RISC, leading to PCSK9 inhibition and which increase the LDL receptors number on hepatocyte, causing greater hepatic uptake of circulating LDL. So this work on a targeted RNA therapy. What important is this? Statins almost daily that we have to use. Targeted RNA therapies, 2 doses per year. That is what the better adherence with infrequent dosing regime. What are the silent clinical evidence and guideline recommendation? It is nothing new. It is new to the Indian context that we have been exposed last 2 years, but the trials have been over 30 years. The majority of the trials that are important are the phase 3, especially these 3 subset, Orion 9, 10, 11 series. 10 leads with ASCVD and 11 with ASCVD and risk equivalents. And this data and the use of inclisiran has now got around 8 years of experience. What it basically does, these are the two important points. It causes a sustained LDL reduction along with the effective LDL-C reduction of around 50%. 70% of the patient achieved an LDL levels of less than 70 and 52% of patients achieved less than 50. If we look at the pooled analysis of three-phase studies, a beautiful effect that inclisiran demonstrated. In Asian population, Orion 18 was done, around 60% effective LDL-C reduction and 56% sustained LDL-C reduction. Very important, that was noticed during the things, it lowers the LPA in Asian patient. Early treatment intensification with inclisiran can benefit ASCVD. That's a core concept of the Victorian Initiate trial, and which is advocating for the inclisiran first strategy. It offers a long-term efficacy. In 80% of patients achieve their pre-specified LDL targets, 90% of the patients achieve their global lipid targets, and on average, LDL-C level were reduced by 50% or less. Orion 8 demonstrated long-term safety, not going into much into that, but safe in renal or hepatic impairment, very important. No drug-to-drug interaction, no off-target effect as compared to monoclonal antibodies. Potential cardiovascular benefits are there, and patient-level pooled analysis of Orion 9, 10, 11 showed early initiation of inclisiran is associated with the numerically lower incidence of major adverse cardiac effect. Inclisiran first strategy was taken in Victorian Initiate trial, and there was 53% of significant LDL-C reduction, 2 doses per year, very easy to give, and again going to the guideline recommendation, CSI 2023, lower is better. So coming to the crux of the clinical thing, which patient would you take on for the inclisiran? There is a young guy on atorvastatin and ezetimibe, LDL-C 120, lipoprotein A 32, misses medication due to hectic work schedule, middle age with complex PCI, multiple vessels have been stented on guideline-directed therapy, LDL levels is still not controlled, often forget medication. Elderly female with recurrent event, the LDL-C of 110, find it difficult to adhere medication due to polypharmacy. All three are target if the LDL-C goal is not achieved despite maximally tolerated statin therapy and ezetimibe. After 4 to 6 weeks, the addition of PCSK9 therapy is recommended. Convenience of 2 doses a year, well-tolerated safety profile. So in the nutshell, what I tried to give you the take-home message, lower is better, is now established. LDL target from 100 that we were usually taught, less than 55, that's the most important paradigm shift in target values. Beyond statins, combination therapies, maybe bempedoic acid, ezetimibe, we have been using it often, PCSK9 inhibitors or inclisiran, they have shown to give enhanced LDL reduction. This slide has been taken from European Society of Cardiology, and that is what the future goes on. We are here biannually. The work is on the vaccination and gene editing. This is one of the most important thing to monitor in the cardiac patient. So target LDLs, target to at a lower level in your patients. Thank you. Without wasting time, I'm open to any questions.
Hello.
Hello. Thank you very much, my friend Dr. Vivid Pratap Singh, for a nice talk. My question is that if patient having ACS or major cardiovascular event recently and having renal dysfunction associated with this, which statin you prefer and how much will the dose? Whether the rosuvastatin, usually nephrologists not prefer atorvastatin over the rosuvastatin.
Very important debate between atorvastatin and rosuvastatin. Rosuvastatin, because of his constant lowering effect, slight further decrease in the LDL-FD. This is the one subset where atorvastatin scores over the rosuvastatin. Although no specific guidelines has set, even the CSI, ACS guideline has set for the both of them, but that is a one gray area in which I as in practice, prefer atorvastatin more. And also when we should be seeing the CKD patient, and we have seen rhabdomyolysis even with atorvastatin. What rhabdomyolysis I'm talking of, the neurology friend will be explaining. Patient statin presenting with complaints of weakness in the proximal limbs, features of myositis, painful limbs, we should always get the CK levels monitored. If the CK levels are high, the statin should be the first drug to go off, and you should be monitoring it that. But to be concise, atorvastatin will be my preferred choice.
It's a great presentation, Dr. Singh. Just as a medicine person, I just want to ask you, with the statin, what is the best preference with the combination therapy, fenofibrate or azithromycin?
Very important question, sir, and very nice. We have a long exposure with ezetimibe. So the combination, the CSI mentioned was with the rosuvastatin with ezetimibe. But the newer trials that have come up now, bempedoic acid has got more reduction as compared to ezetimibe. And that is what the reason of having rosuvastatin and bempedoic combination in the commercial arena. Bempedoic acid has got 18% reduction as compared to the LDL 12% in head-on trials. So bempedoic acid has got a newer and future role for the combination. I personally now prefer a statin with bempedoic as a combination. Even going one step further, the American College of Cardiology 2025 guidelines, they have mentioned that the combination can be any. There is no one fixed drug that should be combination. Even you can go with a statin or a monoclonal antibodies upfront. If a patient has come in ACS, you can legally, ethically also add an PCSK9. There's no point that we have to go and follow a stepwise approach. But coming back to the question, my personal choice with the bempedoic acid, guideline-wise, they have advised rosuvastatin or atorvastatin with ezetimibe.
Sir, one question. At what age one should advise about the LDL?
More than 18 years, definitely. Family history is down there. We should be evaluating much earlier also, but the recommendation wise, they are above 18 years. Above 18 years, a guy should always have his lipid profile. Family history, any sample done down there, we should get it up.
So one more thing. If the patient is having LDL more than 100, does the age matter if the patient has to be treated then
Yes,
50
that-
years or 60 years or 70 years?
So that is what the whole presentation and whole thing is. We are more focused on diabetes. We are more focused on hypertension in last 10 to 20 years of our practice. Cholesterol and the LDL level were least bothered about. As we go into the society where elderly patients are coming, patient with the disease adjusted life year, the patient who have got comorbid condition because of the cardiovascular effect are seeing, we are getting importance of the LDL. So guidelines, what they say, no risk factors, the LDL target should be less than 100. If the patient is LDL target more than 100, we should advise a lifestyle changes, but again 6 months, if it is not there, we should advise a LDL lowering therapy.
So how long one should continue the statin?
That is again a gray zone thing, but what generally we do, patient are thinking once it has started, Dr. Sahab, ye to pure zindagi bhar chalegi. Start the therapy, get the levels down, try to go for alternate low dose therapy or alternate day therapy. Till the point he's able to maintain that target, we should continue. This is what the scientific answer to this question will be.
After achieving the target, we can stop it.
No, just if say patient has got a LDL and less than 100 for 6 months, he's on statin, he wants to go off of the statin, he was on 20 mg, go for 10 mg. He was on 10 mg, go for alternate day therapy. But monitor the LDL levels. If the LDL levels are getting okay, that dose is okay for the patient.
In cases of resistant cases where LDL is not coming down, even in spite of dual therapy, does thyroid function has got some role?
Sir, what?
Thyroid function.
Definitely,
Because
definitely,
hypothyroidism
definitely. Yes, that is definitely linked to it. Definitely, sir. Raised TG levels. So thyroid is one of the important thing which we have to monitor for the LDL thing. But even if the thyroid is low, what the newer therapies and whole the goal was this, sometime which we see now most often that the patient in the zone of around 40 to 50%, in spite of the statins and all, they are not achieving the target, then the role of these PCSK9 inhibitors come to down the point.
Dr. Ram Sharma wants to ask something.
What's the importance of lipoprotein A and B?
Okay, so what the goal is, LDL and non-HDL. They are the two targets which have shown to, when we reduce that, there will be mortality benefit. Lipoprotein A is still in, we are in observation mode. It is known to have a casual risk association with the cardiovascular disease, but lowering it down will be reducing the mortality. This we do not know. But as our scientific evidence will go, we'll further increase. There are two therapies which target the lipoprotein A. PCSK9, which has got incidental finding in Orion 18 that lipoprotein A was reduced, and the second one is pelacarsen. This is a newer drug, but it will only be important when we have got this association that high lipoprotein A is decreasing, it will be getting the benefit of the mortality. So the targets will still now be LDLs and non-HDL targets.
So what are
Sir, I just want to add one.
Hello.
Siddharth is down here.
So
The questions also.
this one problem is that when we get these reports now, the companies have to fill it. So they've started adding lipoprotein little a. Like sir has mentioned, it has not proven till date to reduce lipoprotein little a is going to improve our outcomes. It is just like how HSCRP used to be 20 years ago, telling us that this patient's HSCRP is high, so him having an event, chances are going to be high. Similarly, if somebody has a high lipoprotein little a, chances of having sudden cardiac events will be higher in this patient subset. So you cannot do anything for lipoprotein little a, but you can do for sugar, you can do for BP, you can do for cholesterol, you cannot smoke, you can do lifestyle modification. So it is just something which is telling us that, you know, भाई आपकी चीजें थोड़ी गड़बड़ हो सकती है तो ध्यान रखो.
So
Correct,
what
sir?
are the
Yes,
limitations of RNA-based lipid-lowering agents? RNA-based lipid-lowering agents, what are the limitations?
Cost
And-
is the biggest limitation, sir.
And what are the side effects which are seen during their studies?
There's a local site reaction, that is one only thing. There have been a black box warning of neoplasm, but as such, no drug-to-drug interaction. It can be used in a patient who has got a impaired hepatic or renal insufficiency. Personally, I have been using it across last 2 years, and I've been most number, I will say, in my region. And side effect, I have not found anybody to have so much serious
But in
adverse.
certain studies, evolocumab was found to have increased mortality during the later phases. That is why it was stopped in England. And silscaran was used. Yes.
So
that was
what
thing.
I tell you what the thing was. There was two different strategies.
Yes.
There are two PCSK9 inhibitors. One target the circulating,
Yes.
and the other is the targeted RNA. So the controversy started with the circulating, that is the group that target the circulating. And these effects, because they had got a systemic effect, side effects, that was a time when this drug had an issue. Regarding the PCSK9, it was not. This is a targeted to the PCSK9, and that was a targeted to the circulating antibodies. That is what the difference was. Pardon, sir?
We cannot use expensive medication in this routine practice. So many of the people here are general practitioners.
Definitely, sir. What the thing is, now as the practice will go, you will see a patient who has got angioplasty 2 or 3 times. A single visit to an hospital will cost around 5 to 6 times. What we lack in the practice is seeing the LDL levels. We are not so much fixated about the LDL idea.
Yeah.
The statins, we give high dose, we think that everything is okay. But what the take-home message and why the shift in the understanding is that LDL has to be targeted to a low dose level. So the amount of the patient, and as a general practitioner, you will be seeing much more cardiac patient than us. Very important that LDL has to be targeted. Cost of therapy, definitely an issue. If the patient can say ki bhai cost of therapy, that's okay. But you have to advise, because we have to get to that level to prevent the further mortality.
What is the role of colchicine and other anti-inflammatory drugs?
No, not at all proven because of the kidney toxicity and all those issues. Colchicine, all the experimental stage, not much benefit.
So just the concluding question, if the last one, because we will have a question and answer session also, and that is the one of the best cardiologists in this, I think in the Delhi NCR, 4, 5, 6 are here. So you can ask as much questions that you can, but we have to spare some time. That is why. Just
Any role of Framingham scoring for starting?
Pardon, sir?
Statin. Role of Framingham scoring as a risk assessment.
Actually, sir, what the thing was, Framingham, the data was for the Western population. I think practical Indian subset Cardiological Society of India guidelines are much more specific. Because Indian patient, what we have seen, they are more prone to the cardiac events. And this is a guideline that is more on the Indian patient subset, that CSI 2023 guidelines. You can get it from net, and that should be the target which we should be following on. Rather than blindly going on the Western population is different. They is entirely different. I've worked across in the India also, and once their patient profile is much different, 70 to 80 years, elderly. Yeah, India, the profile is entirely different, 40 to 50 years, high lipid levels, uncontrolled lipid levels. So we should be going in for the Indian guidelines. I think CSI 2023 or LAI, Lipid Association, they are the two guidelines which we should be monitoring on.
So thanks a lot, Dr. Vibhuti, and thanks for the great presentation, both and the basic questions that you. Thanks a lot. Thanks a lot. Thank you. And I will ask Dr. Namit to please felicitate. So next session will be by Dr. Siddhant Trehan. Dr. Siddhant Trehan is MBBS DNB DM Cardiology. He is Senior Intervention Cardiologist with the Maharaja Agrasen Hospital, and he is National Faculty and Intervention Cardiologist, a versatile molecule of cardiology in the generations, and a proctor for complex coronary interventions, TAVR, everything you can think of, and the last not the least and the best one, that he and we have all learned from the Almighty and from the second to the Almighty, which we will ask, I will name after some time, the well known for bypassing the bypass. So bypassing the bypass means the complex of the complex. If you want to address, then you can address him. So I will ask Dr. Siddhant to deliver on he will be speaking on the basic NOVAC, the anticoagulation topic, and then we will have a discussion over that also. Dr. Siddhant, please.
Thank you, Pavan sir, for such a lovely introduction, and good morning, good afternoon to everybody. First of all, a big congratulations to Pavan sir for 10th CardioCon, and it takes a lot to organize such an academic feast for everyone and gathering so many people together on a Sunday just to improve medical care for future. So
my apology for the second for chairpersons. Basically, Dr. Vivek Chaturvedi sir. Sorry, Dr. Siddhant. It was in rush of. Dr. Pankaj Ranjan sir, Dr. Ankit sir, Professor Ankit, I should say. Professor Ankit is from GB Pant Cardiology, and wait for the sessions that they will be mesmerizing in the next sessions. And Dr. Ram Sharma sir, please.
So now it becomes even more difficult to sit in front of Ankit sir and Vivek sir to be delivering this talk on